Hello, everyone. My name is Dr. Rob Murphy, and I'm the Executive Director here at the Havey Institute for Global Health. I'm the John Philip Fair Professor of Infectious Diseases and also a Professor of Biomedical Engineering here at Northwestern. Thank you for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health seminar series. The title of today's presentation is No Praxis Without Struggle, Confronting Othering Through Relanguaging Health Circumstances in Medical Settings. Please take a moment to follow us on Facebook, as well as Twitter and Instagram at hashtag FSM Global Health. That's the address, hashtag FSM Global Health. In addition, we welcome you to become an Institute member to receive access to specialized resources and services that support research infrastructure. For more information, please visit our website, globalhealth.northwestern.edu/members. It's a very simple process to sign up. It takes less than 1 minute. Today, we are thrilled to host Charlayne F. Mitchell, PhD from the Global Health Studies program at Northwestern University for the seminar event. Charlayne is an assistant professor in global health studies and anthropology who examines how race, gender, and class intersect to impact Black American health outcomes. Her work focuses on decolonizing research methods and developing community-involved and evolved approaches to redefine health narratives, particularly through curriculum development and qualitative research centering marginalized communities. There will be time for questions following the presentations, and we welcome you to submit your questions through the Q&A feature, not the chat feature, but the Q&A feature at the bottom right-hand corner of your screen throughout any time during the presentation. And now, Dr. Mitchell, I turn it over to you, and thank you very much for joining us today. We look forward to hearing from you.
Thank you. I appreciate it. I'm going to get my move some things around right quick on my screen. So thank everyone. Thank you for attending my talk, No Praxis Without Struggle, Confronting Othering Through Relanguaging Health Circumstances in Medical Settings. So what does the title of my talk mean? No Praxis Without Struggle combines two concepts. First, praxis. The process of putting theoretical knowledge into praxis or practical application of a theory. It's about moving from abstract ideas to concrete action, real-world change. Struggle, the necessary conflict, effort, and resistance that comes with trying to create meaningful change, especially against established systems and power structures. The confronting part, the othering, is where I actively challenge the process by which healthcare systems and providers treat certain patients as fundamentally different or less worthy of dignity and care. Othering happens when people are seen as them rather than us. Next, I like to move on to just kind of invite you to understand like a little bit of who I am. My life has been painted with many brush strokes, but I'll just talk about the larger ones today. One side of my family are descendants of enslaved individuals, which caused some of my family members to be placed in what the southern part, this Mississippian language is a passer. Meaning looked at white, but considered to have a spoiled identity based on Blackness. From those roots, I unfortunately, this is some background on me, I'm kin to people that are part of the Mississippi Ku Klux Klan that are still living today. And yes, you heard me right, the KKK. And other side of my family plays the rhythmic beats of the Choctaw Band. However, because of the complexities around indigeneity and Blackness, like within my positionality, I only identify within the social construct of Black as my race. So my knowledges are built and are deeply embedded into understanding the encounters and experiences of Black health. I come from a large family. My mother is the youngest of 9 children. And because of mistrust in the medical system, medical malpractice, and a plethora of non-communicable, preventable, and treatable diseases, my mother and only one of her sisters are living. I had 4 uncles, one who died shortly after birth, and 4 aunts in total. I stand situated in Black American feminist thought, where I view oppressed and suppressed lived experiences with an oppositional gaze. In my drive that kind of drive my critical consciousness at the intersections of race, gender identity, and class. My standpoint help kind of guide my graduate career. I did have a corporate America career prior to seeing like the premature deaths in my family and wanting to understand that more deeply. And that's what took me back to school. I have an interdisciplinary training background, as uh, Robert mentioned earlier, with the landscapes within. I have a master's in nutrition and a PhD in global health, where I learned from nutritionists, methodologists, linguists and anthropologists, biocultural anthropologists, medical anthropologists, and rhetoricians. So in my research, interest lay in how Black women and men language their health, maintain their health, define their health risk, and I put those in quotes. Nutrition as a foodscape, stories, identities, cultural food making narratives, and barriers to health. However, my research focus are evolving, not changing because of my interdisciplinary background. So I'm kind of gathering my thoughts around research and how I want to move forward. And I currently have a lot of things running through my mind regarding, like, patient experiences in medical settings that are not born not only out of my research, but out of my personal experiences and the current experiences of my father. And as I talk right now, what I could hear going through my head is him saying, they, medical practitioners, don't give a fill in the explicit blank word, starting with an S, about me, Charlayne, coming out of my father's mouth over the past 6 months. And I've been thinking about also within this complexity of health, my father, and the experiences of the women and men that I worked with, about mental health and how I come and enter spaces that I may not feel as comfortable with in, or am about to engage in a conversation that is heavy, or maybe even shuts off the ears of some people. And so before I even go into depth into my talk, I like to do a 30-second grounding activity. So if you can, I do ask that you close your eyes, and if you have the space to do that, and then I'll count to 3 at some point, and I'll let you know when. And I open the space while counting, to 30, for you to breathe unapologetically. Not caring if you have bad breath or whoever's around you. Just focus on the thought that we have, breaths to breathe and a space to breathe in, that we may feel safe. So I ask that you breathe with the rhythm of my counting. So as in 30 as an in, and then a 29 is out, and so forth. And so as I count to 3, we'll begin. So 1, 2, 3. So 39. So, 30, 29, 28, 27, 26, 25, 24, 23, 22, 21, 20, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. I hope that this grounding space allowed you to breathe at a pace that interrupted the fastness that life brings us. I add a grounding part in my discussion for different reasons, but for you all today, I did it for us to first take a moment to breathe before entering to what I envision as a heavy conversation. And when I say heavy, I think of the memories and all the types of conditions that other, bodies as they carry physical and mental weight. So heavy, when I say heavy, I mean that stuff, those raggedy burdens that are forced onto certain bodies, forcing them to negotiate their being and their belonging. And I want to move into the context of my talk, and this is where I examine how othering functions as a textual machine in medical settings, systematically pushing vulnerable populations to the margins of health through word use and language politics. I ask that you think about a time when you felt othered. And if you say to yourself, I never felt that way, then think of a time that you've othered someone else. And if you say, nah, that's not me, that's you're talking about someone else, then I ask you to think about a time that someone else, or a moment that someone has told you about how they felt othered. So at some point in these questions that I just posed, you have a place at the table of other. And now I ask, what good will you do with your experience or the experience of someone else? So I've listened to and lived with myself the outcomes of frustrating and angering stories about the experiences of healthcare that have muffled or blatantly dismissal or dismissed of medical issues. And when I did my dissertation research and fieldwork, within my research, experience was born a method that used culture, comfort level, let free and not capture language. And when I say let free versus capture language, I'm referring to how all data or text, is captured in qualitative research method, which is my wheelhouse of experience and research. I am mixed methods, but qualitative research is where a lot of it sits. And how those words then at text aren't free because those data get imprisoned in controlling images as implicit biases, intentionally or unintentionally. Health data period can say whatever the analyzer wants it to say. And I'm not here to be anti-statistics or anti-demographic work or demography or anti-health data analysis basher, because those are all great resources. However, sometimes the voices of those experiencing the inequities are watered down into measurements that are exhibited in how practitioners speak to and refer to their patients. And thus my goals and methods for chiseling away at the constructed identity stands on the steps that uplift Blackness, that uplifts the other, and reimagine those forced into the margins outside of the imaginaries of dominant thought. So today, before, I stand before you grounded in space, like working at the roots of these health inequities, because like I mentioned earlier, over the past 6 months, I've been working my butt off to negotiate my father, who is sick, right to health, right to have the best quality of life. And in the words of one of my favorite civil rights advocate ancestor, Fannie Lou Hamer, I'm sick and tired of being sick and tired. But by dissecting language practices and institutional instructions that perpetuate othering, we can expose the mechanisms that dehumanize patients and maintain inequities. And through this critical lens, we can reimagine medical care to center, marginalized voices and to create more equitable, dignifying health experiences for all. And I'm all about defining where I'm coming from. That's a part of my real and my raw. That's who I am. And I define othering through kind of a short poem that I recently wrote, inspired by some of the language used by the Black women that I work with in my research. And it's actually called Defining Othering Recently. And it says, dominance envisions me through a monolithic lens that has been constructed. Biases and manufactured thought that are empty of me. Simplistic phrases, sentences, and laws that gatekeep my being. And so this is how I see othering. And when we say living in this other body, as I stated in my poem, are bodies that are described through monolithic lens, manufactured by and in dominant language. And through my research with Black women, I came to see, as Terrion L. Williamson in her book Scandalize My Name, Black Feminist Practice and the Making of Black Social Life states, Black women negotiating their humanity as a sustained social political commitment to centering themselves while actively struggling against racism, sexism, heterosexism, classism, and other intersecting modalities of oppression that affect even those who do not identify as either Black or female. Therefore, this is why we must transform how we see inequities in healthcare through everyday politics. Because when someone or a community sees themselves through the impossibilities and the deficiencies of the imaginary, there's a collapse in their health. So I ask that you consider these common scenarios in healthcare settings, where using disease labels instead of people's names, speaking about patients rather than to them, and think of as a healthcare provider how using unrelatable medical communication with unexplained technical jargon or oversimplified explanations happen as well. And then that kind of brings us to focusing on the condition rather individuals. And these create distance and reinforce power imbalances. And so describing and prescribing. Our current medical model often offers a linear path. So and this linear path goes to, symptom presentation, to diagnoses, and then to prescription. And so, but what is missing? It's a human element. So a patient's story, their context, their understanding. We need to integrate these elements into practice of medicine so that it transforms into a praxis. And I wanted to understand, this body negotiation when I spoke with Black women who allowed me into their lives to see how their bodies are in the middle. And as I mentioned earlier, my research is grounded in understanding how Black women negotiate, their healthcare according to their knowledges. And what I was taught was that their anger, with the healthcare system was also rooted in hope, that their knowledges would be a part of their surviving. And so there was a pattern formed out of the Black women, that I spoke with. They revealed their definitions of healthiness and healthcare services. Their language of survival in their interviews simultaneously was filled with hope and social and physical deaths. Orlando Patterson developed the concept of social death, but Saidiya Hartman refined the concept from Black feminist standpoint in her book Scenes of Subjugation. By examining Black women's experiences of social death as this systematic denial of their full humanity and social belonging, yet persist this parallel, their resistance and hope for transformation. And then Christina Sharp, another scholar that I like, who's the author of In the Wake on Blackness and Being, discusses how Black life exists in this afterlife of chattel enslavement, where social and physical deaths are ever present, yet survival and hope persists through what she calls wake work. The consciousness practice of living and hoping despite conditions of death. And for those of you who are fortunate to not know what a wake is or need to be reminded, a wake in a funeral is a gathering of friends and family to pay their respects to the deceased. Unfortunately, usually like this is held, before the funeral ceremony, where people can view the body, often in an open casket, and spend time with their family to share memories and offer condolences. And the term originates from staying away or to watch over something or someone. And the simultaneity, that I'm proposing is something that Hortense Spillers in her 1987 Mama's Baby, Papa's Maybe calls the paradox of non-being, where Black women's narratives contain both the recognition of their, and also my systematic negation, social and physical deaths, and their persistent assertion of life and possibility. This duality in their and my language, as both a recognition of devastating reality and an insistence on survival and futurity, or existing in the future. And I'd like for you to sit with that last part, existing in a future. So because if we, cannot see themselves in the future, then there's death. And here I come to, the grave digger. And when there's death, there's typically a grave. And understanding with the question I mentioned in the previous slide, what is missing from our linear medical model? The answer was the human. And when the human is missing from an element that should be saving their lives, you may find them in the grave. And to have a grave, there must be a grave digger. And here is an acronym that I created that I believe represents barriers to effective healthcare communication, that creates the grave. And so generalizing patients, rushing interactions, assuming understanding, vocabulary that excludes, and eliminating patient voice, which at each element contributes to the othering in healthcare settings, leading to crafting the skill sets to become a grave digger. So slowing the grave digging through listening. Returning to the Black women who shared their health journeys with me in my garden, my research garden, as I call it, enrich my understanding of how some Black Mississippian women navigate and negotiate their health. And I titled this next slide, slowing grave digging through listening, because what they shared with me, some solutions for slowing down the grave digging. And the theme at the highest decibel was quality care cannot exist without listening. So poor communication in health can have serious consequences. Each misconnection, each failure to truly listen digs us deeper into problematic practices. However, active listening can slow down, or even stop this pattern. And when we truly listen, we understand context, we build trust, we create better patient practitioner relationships, and ultimately improve outcome of those forced into the margins. So now that we've got to listening as a tool to slow down grave digging, but I want to ask, but what does this listening mean? And before I even show you the title of my next slide, I like to speak, from an ableism, sensitivity, reflexivity point, because it has the word, listening in it. There's no need to have the ability to hear, to listen. And so, but many practitioners struggle to listening to where, I get this overall thing of my discussion, no praxis without struggle. So listening becomes merely a performative, a struggle, when it exists as abstract knowledge without concrete action, operates from a form of virtue signaling that centers the listener rather than the speaker, fails to translate hard experiences into material change or support, and divorces the act of hearing, from responsibility to respond. And the question, how do we inform our ears to turn on, points to the need for cultivating intentional listening that leads to action. So, however, without praxis, this turning on is a struggle and becomes a form of consumption rather than engagement, a form of accumulating knowledge without shouldering responsibility, performance of awareness that doesn't disrupt existing power relations. The struggle reveals how listening without practice becomes uncomfortable rather than challenging, static rather than transformative, individual rather than collective, and abstractly theoretical rather than material, like consensual, consubstantial. And so I like to flip and reverse this all. So listening, requires struggle in healthcare systems and healthcare performative recognition. We hear you, this whole we hear you thing, while maintaining discriminatory practices, creates what Dorothy Roberts calls this deadly interaction, where awareness without structural change perpetuates rather than prevents death. And medical listening without action directly produces Black death. And when healthcare providers hear but don't act on Black individuals' self-reported symptoms, the gap between acknowledgement and intervention becomes lethal. And true medical listening requires dismantling both individual biases and systemic racism. It's not just about hearing symptoms, but about transforming the entire infrastructure that determines who lives and who dies. And so therefore, you must transform from a grave digger to a path digger. And so shifting, there's a lot of, shifting from the grave to the path digger. And so there's a lot of tools that assist in moving dirt, or what I'm saying here, rely on what I'm referring to here is more the systemic barriers that force certain bodies to their grave prematurely. But we want to find a path or a pathway in opposition of a grave. And so a path, this acronym that I've come up with, is like that's, it's this personalizing care for the individual. And I know in medical settings, like that personalization kind of gets like there's not time, right? But we can still, have active listening and engagement, be transparent, sharing of all relevant information and options, and honoring patient autonomy informed decisions. And this path emphasizes crucial ethical principles of transparency, patient autonomy, and directly addressing power dynamics in healthcare relationships. And this pathway, I've been struggling a lot with this, like I said, with my father, and a lot of this honoring patients' autonomy and informed decision, and this transparency has been very transparent to me that it doesn't exist in a lot of settings, especially those who are in other bodies, but also have an insurance, that is not seen as something, that is the best to perform the best services with. And so I'll leave you with, one of the most I'll leave, with with some of the most frequently used tools to create a path or build a physical path that I have transformed to represent a path to equitable and quality healthcare for underserved and underheard individuals. And so most, have heard of you probably have heard of these tools, and you're probably like, she's using these construction tools to give an example. And so building a new path to health care. And I asked, like, will you be an excavator? So an excavator is a large, versatile machine with a cabin, a long arm, and a bucket that can dig and load earth and rock into trucks. Excavators come in different sizes, including mini, medium, and large. And so in what I'm thinking about this excavator in the medical setting or in a communities who want to uplift and to reimagine othering, the excavator becomes to make large scale systemic changes. Or will you be a trencher? A trencher is a construction machine that digs trenches for laying pipes, electrical cables, and drainage. Smaller trenches can dig, trenches that can be 1 to 4 feet deep and 4 to 6 inches wide, while larger trenches can dig ditches up to 18 feet and 4 feet wide. And this trencher, and what I'm thinking about, and where your place could be, is it represents and creates organizational policy reforms. And then there's an auger. It's a large drill that with a spiral metal shaft and blade that end with bores, and it holes that bores holes into the ground. And augers come in all different sizes, too, and from handheld to tractor towed. And when I'm thinking about the auger here, it creates focused collaborations that will work with underheard and underserved individuals and communities and not on them, to get sustained solutions. And next are the shovels and the hand tools. So shovels are a common tool for digging, lifting, and moving materials like soil, coal, and snow. There are many different types of shovels, designed for specific tasks. And then the hand tools, or the other tools for digging include spades, forks, digging bars, post hole diggers, mattocks, and picks. Um, but here, the hand tools and the shovels are the individual daily practices. Each has its place in creating change. And so creating the road to more equitable health. Um, as I conclude, to the road to more, thinking about more equitable health, all of these construction type machines, turn tools to reimagine health and health equity are important, to hold in your critical consciousness, because building better healthcare requires, conscious choices around our words that we use, active listening practices, patient-centered communication, cultural humility, and ongoing education and awareness. These elements create a foundation for more equitable health outcomes. And then Ralph G. Nichols and Leonard A. Stevens in a 1957 paper that it was called Listening to People. They state, if we hear something that opposes our most deeply rooted prejudices, notions, convictions, mores, or complexities, our brains become overstimulated and not in a direction that leads to good listening. This perfectly illustrates, how medical providers and practitioners' emotional filters can create what Harriet Washington's calls this medical apartheid, when medical providers' deeply rooted biases prevent them from truly hearing, concerns of the other, creating a deadly gap between acknowledgement and intervention. So true medical listening is a struggle that requires dismantling both the individual emotional filters, that systemic barriers that prevent effective hearing and response. So we need a healthcare system that struggles to create the necessary conflict or good trouble, as the late John Lewis said, to dig pathways and not graves, creating practices that see patients where they are and not past them. And so there's no praxis without struggle. And I've ended a little early, and I thank you all, and let you know this is not the end of the conversation. It's the beginning. And your experiences and insights are, invaluable in doing and being committed to this ongoing work. So thank you. I welcome your questions and your comments.
Well, thank you very much. I really appreciate this perspective and your presentation. And we do have some time for questions. There's just one in the chat, in the question and answer box now. They're asking, Dr. Mitchell, what are your pronouns? It's a very technical question.
She, her.
Okay, great. Thank you. I think let me start with basically the elephant in the room in this timely presentation. All things going on with the government and funding and the NIH and CDC and DHS, DHHS. How do you think that's going to affect your field, and how are you going to adapt to some of these changes that are coming online right now?
So it's very timely that you asked this question. So I was teaching social determinants of health on Tuesday, and we were doing midterms. And the midterm that I have them working on is around a debate. And then I explained to them the debate is not an argument, and sometimes it might not end in this conclusion. But they were taking one of the 5 major categories of the social determinants of health, and they're using that to debate, some topic. that they come up with. And a lot of them looking into these topics, they got information from CDC websites or like before they begin to disappear and on their topics. And so I asked, that's something that I asked them. I said, so what do we do, when we don't have what we deem as information that is scholarly, that is evidence-based? What do we do when we don't have access to those things, to leverage, what to show, like that, we have some type of like grounding on what we're saying, and I asked that to my students and like, well, anecdotally, like, do we do things that way? Or, or do we, and I said, well, we have to continue these conversations in spaces, like this, when things disappear and how I think about, a lot of things were not, written in certain cultures. They were oral communications that happened there. And that didn't mean that those things were not valid. They were not evidence-based, because they saved lives. They were also, they were things that were repeatable, that were able to go in and to show that this works, for this group or set of people. And so with all of these, the effect here is how do we work, under, around, and over with something that's been taken, from a road that's been kind of taken from underneath our feet. And so therefore it's almost like going back to listening to people, what I talked about earlier, and creating communities outside of what we had deemed as this space that we have to go to find information, because a lot of information has been there and actually erased the things that didn't even exist, before. So how do we go back to having conversations and seeing people where they are, and utilizing those text, those stories and those narratives to help to negotiate how do we have better health.
Question in the QA box is, how does this relate, or is this the same to cultural competency?
Okay, so I've explained to my students that, that I have a little bit of issue when I take on the word competency. And so competency, I feel, is everyone cannot be competent with other people, when we have those who we are not a part of that, that culture, or a part of that ethnic group, or a part of that, social construct of race. Like, so you can't be competent in someone else's struggle, but you can understand, you can have humanity, you have humility. So we have to think about, what does competency mean? Competency means that you are a part of that struggle, you're a part of that situation. And so I don't believe in the competent piece. I believe in the humility, the understanding, and the listening to understand, and intentionality that goes behind understanding what is occurring in a group, because the knowledge is already there, within that space. The knowledge is already there within the culture, within the group. There's already groundwork that happens. So you can understand, what's happening, but the competency, if you're not a part of it, no. So I feel like there's a difference between the two.
All right, another question here. Active listening also requires time, which practitioners are increasingly limited on. Clinic schedules are packed and income is often directly tied to productivity. How do we also support providers and protect them from being spread even more thin when biases and rushed interactions are most likely to occur? Very tough question.
This is a very tough question. And this is something where we have to almost up to truly be able to have a solution for that question. It's like we're going to have to totally undo what we've done, and then redo it, to be able to have time, because time, I know that's why I mentioned in that piece, like I had time on there, are spending more time. And I know that that's something that's 15 minutes is probably about as most that you're going to get with a practitioner, unless you have like a PA or something like that. So how do we implement more people in the medical practice that are like that have how do we create more positions that maybe can touch people where the doctor comes in, you know, and gives their piece, but then there's someone else and some type of advocate that's there as well outside of like the, you know, the more diagnosing and prescribing piece. So I know that, but there's also, I can tell you this story about my father, and my vulnerability. So I've had to been listening in on a lot of, I've gone to a lot of his appointments, but I've also had to listen in on some of his. And so he had an ENT appointment, and he had, and this was a Black woman, that was MD. And so I was listening in on the background, and she only had like 15 minutes with him, but she took, in that 15 minutes, she acknowledged him. She listened to him. She didn't make him feel as though he was nothing. She didn't make him feel like he was just another, you know, Medicare, Medicaid patient, you know, that, you know, with insurance that, you know, may or may not, you know, pay her, you know, or it will take time. So I feel like there's other pieces that, you know, maybe there's not as much time, but what do you do with the time? And so that's where I kind of like, how do you feel that time to be able to make that patient feel as though you care? Because I've also been in the room with my dad when there was the provider that came in 15 minutes, and myself as well. And they were like, and they made me feel like I was a problem. They made my father feel like he was a problem. And so, how do you, if we can make that, turn it from this transactional to transformative relationship, I feel like it'll be a little, the time can come as when we can maybe add or find, you know, monies and that allocated and in the positions where you can have someone that can come in and spend a little bit more time with the patient, maybe after the practitioner. So that's my 2 cents. But, and I hope that I kind of answered the question
Well,
in some
I think
way.
you handled that pretty well, considering how loaded that question is. Thank you very much. All right, I don't see any other questions in the box there. If anybody has one, put it in right now. Otherwise, what I'm going to do is just thank you, Charlayne, for sharing your insight and expertise with us today. Thank the audience for joining us and for asking your thoughtful and provocative questions.
Yes.
We'll invite you to join our next Havey Institute for Global Health seminar, which takes place virtually via Zoom on Wednesday, March 5th, presented by Catherine Semrau, PhD, MPH, who's Deputy Director of Ariadne Labs and the Director of the Better Birth Program at Brigham and Women's Hospital and the Harvard T.H. Chan School of Public Health. You can register via our newsletter, Planet Purple, and our social media pages. Again, thank you for joining us today. Thank you, Charlayne. Recording of the webinar will be available online and will be shared via our newsletter as well. And this concludes today's webinar. Thank you all very much. Thank you, Charlayne. We enjoyed your presentation.
Thank you. Have a good day.
You too.
Thank you.